So thank you, Tim. Thank you all for being here. It's a really honor to having been representing the association and serving for all of you who are here. And so let's start the topic. My talk is about shaping the future of HPB oncology. And I can already anticipate this will be a conjoint talk. So what's the America's HPB legacy? So as we know, cancer is a leading cause of death all around the world. And in the United States, it's usually the second most important cause of death among all the population. Though, if you consider the last years and the group age of 40 to 80, it's turning the first cause of death so far. So in many countries already happening. So this is a very important public health issue that we have, and is probably growing every year. If you consider the United States statistics, demographics on cancer, you see that the HPB malignancies are responsible for more than 112,000 new cases of cancers a year, and around 80,000 patients that will die for cancer. But more than that, if you consider also the patients with colorectal liver metastasis or other metastases, you could increase here around more 20,000 cases a year. You could imagine this all over America. And surgery is still the main chance of cure for these patients, especially if early diagnosis is possible. This is a main issue, so you should have this in mind in order to increase the chance of cure for our patients. So it's also important to understand from where you come from. So HPBA was inaugurated in Chicago, Illinois in the year 1994, a few months just after the IHPB was founded in Boston, Massachusetts. And since then, much has been done. Nowadays, we are more than 1,000 surgeons all over Americas, from more than 20 countries, many institutions, increasing diversity, and a wide range of age groups too. We are a continental association. We have a solid membership with over 19 chapters all over America, as you can see here. I think it moved. Can you come back to my slides, please? Thank you. And what have we done so far about HPB malignancies? Well, I can say that we are very committed to the welfare of our patients. And we can see this everywhere in the meetings, in the discussions, and the daily work we see all around the continent. Since the first congresses, we have always focused on surgical treatment for cancer with deeper and multidisciplinary discussions every year. We treated patients directly in our daily activities, besides knowledge creation, research, promotion of careful and personalized healthcare. We have done, and thanks to initiatives of many here, but especially Gazi, many humanitarian outreach also. And many of these patients were treated of cancer disease, of malignancies. Much have been done also individually, isolated initiatives with producing research and studies regarding cancer therapy and cancer care. So I can just cite here a few of them, and many guidelines have been produced in order to keep the best standards all over Americas and the world. Besides that, we have initiated the Clinical Trials Committee, and thanks to Mike and many others who are in this position now. And we are just at the moment to have our first finishing accruing study. So we have our first association-produced clinical trial in AHPBA. Education is a very strong landmark of our association. So with annual congresses, journal, courses, grand rounds for fellows, the fellowship, and also we have just started our patient education program, which is the first step of our patient experience project that's going on. Besides conjoint initiatives with IHPBA and other associations. Our membership has increased, and then this is a stable number. Harmonization is a reality with many benefits for our members. Based on combined actions with IHPBA, we have open doors to Americas and other countries too, and diversity is a strong landmark of our association too. We have been creating the strategy, and I would thank Chuck, Charles Vomas for the last initiative here. So we know we have organized it now so we can understand better where we want to go. And also you have built our marketing plan that will give the roadmap to implement our strategic plan. The foundation has done a lot. And here are only some initiatives. And please support the foundation. This is very important so we can keep going and increasing our grants, scholarships, and much more. And what's to come on HPB oncology? So what's the future here? So I asked some testimonials from some of our members so they can help us and they can give the ideas on what we can expect on this field of knowledge of HPB surgery. So
multidisciplinary HPB oncology care is here to stay. What the AHPBA needs to do is provide the platform that allows surgeons to always be at the table, always in the lead of taking care of our HPB oncology patients. We must leverage our tangible and intangible efforts. We have great assets from our membership all the way through our foundation, and intangible strengths such as leadership, integrity, and a global presence. This is how we should contribute going forward.
And thank you, Mark. So then what's to come in the field of HPB oncology? So let's talk a little bit about personalized therapy. So it's much in vogue, this topic. So personalized cancer therapy is a treatment strategy centered on the ability to predict which patients are more likely to respond to specific cancer therapy. At least this is one of the first concepts of personalized therapy. Modern concepts and other concepts have come. So precision oncology, now it's precision oncology as a cancer diagnosis that involves diagnosis, prognosis, prevention, and or treatment tailored specifically to the individual based on genetic profile of the patient. So using a lot of genetic molecular points here. Also, tumor biomarkers may also be associated with patient prognosis and tumor's response to therapy. But is personalized therapy only that? And treatment may be also guided by the same genetic mutations that may share independent of ordinary pathology studying. So maybe we are talking on very individualized care where each patient has a unique tumor and each patient will have a specific treatment. But is it only the way we can face personalized therapy? I think here is a very important point here to discuss when you talk about the future of HPB oncology and personalized therapy. So these are some testimonies from the Pancreas group, which I think it's very interesting. So we think the precision medicine's biology and genetics markers will guide treatment options, of course, but personalizing care can also mean taking patients' feedback and experiences into account, focus on managing symptoms and side effects, and working together to create a plan that fulfills the patient's goals and wishes. And I think this is a very important point here. Personalized care may have a broad range of options too. So here are some of the most common ones that have been studied. And I'm gonna highlight at least two of the most important now, as immunotherapy. So tumors arise through a combination of genetic and epigenetic changes that facilitate immortality, despite they create foreign antigens too. Nevertheless, cancer cells manage to escape immunorecognition and subsequent destruction. They are particularly efficient at suppression the body's natural immune response, as we know. It encompasses a variety of approaches that mobilize the immune system to seek out and kill cancer cells. And recent advances on some therapist regimens, such as the monoclonal antibody blocking CTLA4 and PD-1, have boosted the development and increased the interest in the treatment modality. And what to expect then? Well, there's a spectrum of available immunotherapy, as you can see here. So it's not something new, actually. It's now in vogue because of many of the advances and the result in some specific tumors. And is it the beginning of the end of cancer? Well, I don't think so. This is probably one more tool that we will use. And some would even ask if it's the end of surgery for the near future. So we don't believe this either. Another possibility of using the target and personalized therapy, the gene therapy, that aim to modify, delete, or replace abnormal genes as a target cell, such as primary tumors, metastases, or CTC, for example. What about artificial intelligence? Well, artificial intelligence and machine learning have been recently boosted. It's not something new too, either. So, thanks to hardware improvements, we now have algorithms that can learn, predict, and advise based on vast amount of data. And it came in a good moment where physicians and researchers have a bunch of information, and we should understand how to use that information in favor of our patients. So that's where AI comes into play. Some big facts on artificial intelligence here. So, an important fact, in the United States in 2016, former President Obama launched the White House Cancer Moonshot, as you know, a program to increase awareness of the importance in accelerating progress towards cancer prevention and treatment. The goals would be breaking down the data barriers to create a comprehensive global cancer network that can accelerate the integration of genomics, epidemiology, and clinical information, the precision oncology. Many would be the utilities of artificial intelligence in medicine and in surgery. So it could be a diagnostic tool, a tool also for precision medicine, and also it could be used to reduce trial costs, and costs of treatments, for example. Along with that, we have this term, the radiomics, which is the use of artificial intelligence in order to facilitate or improve the diagnostic of some lesions, especially lung and liver. And usually it's more nowadays used in order to help the physician in improving the diagnosis. But much have been done in this field. What about surgery? Well, let's listen of one of our very known member of our association here.
With respect to the role of surgery for HPV malignancy patients, I believe that we still have the only chance for cure. With respect to the future of HPV oncology, we finally now are having some neoadjuvant and adjuvant therapies which are more effective, but I believe that this will actually increase, not decrease, the number of patients coming to surgery. Finally, with respect to the role of the AHPBA, I believe that we should continue to conduct clinical trials aimed at reducing the morbidity of our operations, such as the current Whipple antibiotic trial and the proposed hepatectomy drain trial. But also, we should encourage key leaders of the AHPBA to be very involved with the design and conduct of NCI-funded trials for our patients.
Thank you, Henry. So what about precision surgery? We could use the same term as precision medicine. Maybe we could include this as a precision surgery. So in the past 20 years, the concept of surgery has undergone a profound change. surgical practice has shifted from focusing only on eliminating the tumor, being so radical, to achieving optimal rehabilitation and organ sparing. So optimization of cancer surgery consists of maybe 4 cores, as I understand. So it would include removal of lesions, which is related to a lot of radicality, organ protection, maybe less radical, injury close monitoring, because when dealing with surgery, we, of course, want to have the less injury as possible, but you have some injury, no way without that. So not to harm, no, maybe we need some harm. And controlled surgical intervention, which means be prepared and know the possible contingencies that we may need to take during the treatment. So what's going on this situation? So I think removal of lesion, of course, radicality is very important, but also, yes, we need some organ protection to the right measure. And injury closing, monitoring maybe, but harm what's necessary only. And controlled surgical intervention, I think we always should do that with good quality of data and put in balance what's good and bad for the patients. What about surgical education and big data? So big data may be coming in a direction to help in certain way, mainly the education, I think, my point of view. So we can remember that a large number of surgical videos are available to be analyzed through machine learning using computer vision principles to achieve automatic real-time analysis and segmentation of surgical procedures. So possible gains must become in order to help people in education for invasive surgery. So they'll probably guide us or guide young surgeons and try to check during the surgery if all the steps are going well. What about robot surgery? So new robots are to come now, new platforms, different ways to use it may be implemented. Once maybe the arms will be separated, more possibilities or combination with laparoscopic and open surgery. This may become more accessible, and also some of these products may come with artificial intelligence, including the possibility of improving education and maybe for the very far future automated surgery too. So these are possibilities that are to come. And one important concept here that has been discussed a lot in the research field is not only integration, but also the convergency, which is the integration of many fields of knowledge in order to improve a specific field, in our case, the healthcare. So here are some examples, and thanks to Mariano Jimenez, who sent me some nice slides, nice pictures here. And also, so you can see here a very good example of convergence, where you can see the engineering, the imaging, and virtual and mixed reality in order to help minimally invasive surgery and also help interventional radiology. So, by the way, let's listen what Mariano has to say to us.
The future of the surgical treatment of HPV cancer will be closely linked to technology. The near future will be marked by less invasive and more precise interventions, the use of needles, energy, ablation, a guidance system, augmented reality, the use of percutaneous and laparoscopic procedures in the same place in our new hybrid operating rooms. The more distant future will be robotic, flexible, and autonomous. The international recognition of our society positions us in a privileged place, and this comes with a big responsibility. I believe that we must take care of training in these new skills. We need to encourage research efforts in these areas and continue the work done in terms of raising awareness among the population.
Good.
The future of this.
Thanks. Now let's go very quickly, specifically in some specific disease sites. So here, pancreas. So what have you learned from pancreas that can help us to the future treatment and care of these patients. So personalized therapy for pancreas cancer, I think one very important advance was understanding that we may have different pathways of carcinogenesis with a multi-step that accumulates signatures of mutations along the way. And this can help us to target the treatment and to classify as different groups of patients. So as we can see here in 2016, so we may have now, with the same adenocarcinoma package, at least 4 different kinds of adenocarcinomas, different adenocarcinomas that may bring to the future new opportunities for treatment and for patient selection for the timing of surgery, for example. And many opportunities are now for personalized therapy, such as attacking the stroma or attacking the infiltrating tumors, monocytes and macrophages inside the tumor, DNA repair, or even for tumor metabolisms. What about the surgery for pancreatic cancer? What advances can we bring to the future in HPB oncology? So focus on decreasing the morbidity of pancreatic surgery is key, of course, and there are a lot of studies going on. Redefinition of resectability is also a change that has been made during the last decades through vascular reconstruction and the use of neoadjuvant therapy. So sometimes the patients we resect now would be considered unresectable 10, 20 years ago. Better studies regarding perioperative oncologic impacts of vascular resection are still needed, though, and combining treatment are critical. The jury is still out, though, from the timing of the surgery in this setting. Another important concept that came out was borderline resectability, which is a subgroup of patients that may be between resectable and unresectable, even though sometimes technically they are resectable. But there's a very important understanding here that these patients are at risk of sometimes positive margins or early recurrences systemically. So that's where the discussion on neoadjuvant therapy may come in. And there are a lot of studies and a lot of interest on the neoadjuvant treatment for adenocarcinoma of the pancreas. Minimally invasive techniques are still a lot of groups with a lot of experiences, but the data is still very weak. For distal pancreatectomies, of course, most of the institutions do it by minimally invasive surgery, but we still have limited data on that for cancer. About the tumors in the head of the pancreas, the Leopard 2 was a negative trial, but probably we will have very soon new trials on that setting. What about ultra-radical approach? Maybe we are talking about less invasive and preserving the function, but sometimes maybe we will have patients that you have to be still very aggressive. So maybe you are for very selective patients with limited disease, an excellent and persistent response to systemic therapy in very well-fit patients. There's also a lot of studies going on irreversible electroporation, which is a treatment that destroys tumors using pulsed, low current, high voltage electrical energy, which creates permanent pores in the cell membrane, leading to irreversible apoptosis and cell death. So there are some interest, and this study showed that maybe in the group of patients that did IRE treatment compared with patients that did only radiochemotherapy had some benefit on survival and resectability too. And I think a very old topic, but it's still very important to the future, because when you talk about complex surgeries, and HPB surgeries are complex, centralization historically has been shown to improve the resectability for the patients, improve the safety, decrease mortality. So I know that in Americas this is a big issue yet, and I think that's something that we as association could try to guide to the near future. What about liver and biliary? There is still some tentatives of classifying subtypes of molecular tumors. This is an example for Asian HCC patients, where they classified molecularly 2 subtypes of cancers. And also for colorectal liver metastases, there are chances and tentatives to classify better patients in order to choose and select which patients could benefit more or less of a surgical treatment, for example. So then let's hear one of our very well-known members here.
HPBA contributed greatly to the development of HPV oncology, defining resectability in colorectal liver metastasis and pancreas cancer. HPBA leaders contributed to the development of the new AJCC HPB stagings. Progress will be met with success if we continue to collaborate with our colleagues in interventional radiology and medical oncology, developing new treatment sequences and guidelines, collaborating in new protocols, including immunotherapy and targeted therapy.
About surgery for liver and biliary diseases. So you have, and thanks to Mariano again for this nice video. So for CT, you have a lot of advancements. So we have a higher resolution now, a large amount of information. It can improve our 3D visualization and surgical planning that will probably help us in the future and will help a lot in the education too. You may use also the Indocyanine green molecular fluid. Some groups use it routinely. You can use it to select better the segments you want to resect or to analyze a hepatic function during the surgery too. And what about liver transplant for malignancies? So there's a cute discussion, a great discussion on that. Here's the timeline. So here you have an increasing indications for surgical treatment for transplantation. It started with HCC, then neuroendocrine tumors, then colorectal liver metastasis, and cholangiocarcinoma. There are still some studies going on, so we still wait for the near future and the results for all this research. And how can HPB, once talking to the future, how can us be prepared to treat HPB malignancies? Well, I'd like just to do a parallel as with all these testimonials and maybe some data we have, that for medicine and for surgery, we have some very important moments in history. So we had the antibiotics, anesthesia, and hemostasis with electrical scalpel was a great jump to the future by that time. Then for oncology, we may have the Halsted principles, active agents for chemotherapy, new molecular understanding, and I think now maybe we have to balance each time more the radicality with the sparing of function. Minimally invasive techniques and robots are here to stay, and multidisciplinarity and precision medicine will be probably the key for the near future for us. Let's hear what Javier has to say.
AHPB's role in developing cancer care for patients with HPV oncologic disease has been sustained through the principal actions of our organization: education, training, innovation, and research. However, the future in oncologic care is changing in several aspects. As a transplant surgeon, I must say that the transplant oncology field is growing and will expand more in the next years. The integration of new specialists in the oncology multidisciplinary team will be the rule. Personalized therapies for each patient will be another big change. AHPBA involvement in the new advances in the field is crucial, and clearly, AHPBA has a central role for defining the future of HPV oncology.
Another one.
I think that the HPV associations played a major, even a crucial role in the treatment of patients with cancer nowadays, because we have developed a lot of consensus guidelines of statements regarding treatment. We have developed neoadjuvant treatment as well as adjuvant treatment. I can only speak from pancreatic cancer treatment, but here we, the surgeons, were the ones to develop adjuvant chemotherapy in pancreatic cancer. So the associations have played a major role.
And so what about research? So actually that's something that we should advance a lot as an association, and we probably should do more conjoint studies and also exchange experience with Latin and North America, do some cancer registries, based on also the research on cure and quality of life, early diagnosis, not only treatment. So I think this is very important. So it should be patient-driven. with the precision medicine in mind, and also regarding cost and accessibility in order to attack disparities all around the Americas. So the PEP project, just updating, we have this second, third, and fourth waves that should be awareness campaigns, health promotion, understanding disparities, and also include the research within the project. So this project is
The patient
then
experience
kept
project
in.
is so important because it is all about our patients. The whole objective of this project is to provide our patients with accurate, easy to understand information about their disease. We have descriptions of benign and malignant hepatobiliary processes. We have videos from experts in our field, many of whom are in this room, giving advice to patients. We also have videos about surgical procedures so that the patients can understand what operations they're going to undergo. And finally, eventually, we're going to have information about nutrition and exercise, as well as patient support groups. We want you to have a website to refer your patients to that can augment the details that you've already provided them, and they can find all of this information in one easy place on our website.
So education we should go farther on education and keep our conjoint efforts and be much more inclusive, better experience for all. We had this year the Latin American Peruvian, and we will keep it for Argentina and then Brazil. The ultrasound course was very successful in Peru, and also increase our traveling grants. And I think Paulo has also something to say about that.
Place here is continuing and developing educational programs as fellowship grants must continue, especially for research, and also travel grants between HPB groups and Latin and North American groups for the exchange of experiences. Second question is, what do I think about the future of HPB oncology care? I think we need more and more multidisciplinarity, and of course, more minimally invasive approaches in the treatment of HPB malignancies. And the third one, about the role of AHPBA and its members in the future of HPB oncology, I think that we must provide more and more education for multidisciplinary teams, stimulate HPB fellowships in all Americas, and stimulate the change of experiences between HPB groups. I think
AHPBA has been very important and instrumental to create, support, and unify all the regions in the Americas. With the annual meeting in Miami and the different chapter meetings, the oncological care of many health problems as pancreatic or liver cancer has improved. In my country, as the Mexican chapter and Mexican HPV Association, we have been working to educate physicians in early diagnosis and prompt referral, as well as unified criteria for better treatment.
Good. Besides that, outreach missions are going on more to come, Brazil, Peru, Iraq, and possible alternatives to our model now, first and second steps, when we go and the group comes back to one of our institutions. Besides that, prevention, we should go for some work on prevention, so we should come with better outcomes, more cures, possibilities, more cost-effective, probably more surgery. So, in conclusion, I think we can see a lot of consensus on what the data have, how we can achieve it, and a lot of the opinions of our members too. So I believe, can we shape the future of HPB oncology? I think we do. We could do that. We can do that. We should work hard, work together, exchange much more, be creative, innovate, use technology in our favor. Research in all fields are very important. And mainly, understand patients' opinion. Early detection and prevention should be something that we should search for. And learn more from our mistakes and from each other with the best information available, which, in my opinion, means the integration evidence that we are discussing in this project. For now, I will make a quick stop. And besides the final conclusion, I would like to know some acknowledgements here, please. So, as Tim already showed, I'd like to acknowledge my university when I became a doctor at the medical school. Also, when I lived in Belém, there was this hospital. From my background, where my grandfather actually was a physician there. So I did a lot of things in Hospital da Ordem Terceira. Then Santa Casa and S. Camargo, as Tim already showed. I'd like to highlight some mentors I had, at least during my HPB formation. So Ademar Pacheco, Arnaldo Zutan, André and Paulo who are here, and Ademar Lopes too. This is the group I work. So without this group, I couldn't do half of what I do now. So here is Wilson. He's actually in USA now, in Houston now. Alessandro, André, Igor, and Herbert, that you probably know, many of them. And there's a new one called Silvio. He's not here these days. Regarding the HPBA, I'd like to thank to all the executive council here. Really, it's a team job, and I'm very proud of being part of it. And I'd like to highlight some references I have in the association. Since the beginning, they have also supported me. I know they support many other guys here. So especially, I'd like to thanks to Nick Volte, who was the guy who invited me to come into this association. And there's a funny story, because when he invited me, it was just a few days before Diego was born. So it's like a child to me. So I am already 9 years in this association, and I'm very happy with that. Also, Javier, who also supported the Latin American, and more than that, he can do the connection with all the association. Gazi, Will Chapman, Will Jarnigan, Rebecca, Scott Helton, Sean Clary, that really proved to be a very hard-working, smart guy. Magella, Mariano, Tim, Paulek, Mike D'Angelic, and many others. So I'd like to thank you all, guys. I'd like also to thank my predecessors, the past presidents. I know they are not all here, but this is from the last meeting, and I'd like to say I'm very, very happy and very honored to be part of this group now. And also I'd like to thank to Margie and Jill in the name of the whole group of LP, who did a great job during this whole year and also in this meeting. And they really do most of the job, and sometimes we have already it done when it comes to us. So thank you very much. I have a lot of, during these years, surgeons and friends. I couldn't tell the names of everyone, but here just to represent most of the people I got to know and I live every day. Some more friends during these meetings, during these last years here. My family, who are very important, of course. So here, my grandparents. Here is Atahualpa, who was a physician. And by the way, his name, Atahualpa, so he calls me to our Peruvian guys. So Atahualpa was the last Inca king. So we don't know exactly the connection, but you may help me with that. Also, Valdomira, my grandmother. Also, my grandfather, José Coimbra, and Catarina Coimbra here. And here, my brothers, Alexandre, who just arrived from San Francisco now, yes. And he is my older brother, and I'm very proud of it. Here is Carolina, and then Gabriela here. So we are 4, 2 women, 2 boys, 2 men. So, and my family, as you can see, as Tim already said, there's a big family in São Paulo, not too much, but in Belém, very big family. So here are some examples. And my parents, that are probably the most important thing that happened, and they really guided me. And by example, I can say that everything that I have now is because of them. And here, Thaisa. So it was very hard to choose a picture. So I decided to choose only one because I know, at least I think this she'll like it. And what can I say about Diego? Well, Diego, I think, was the best thing that happened to me. E portanto, eu quero dizer que fico sempre muito emocionado quando falo deles. Né? Então, eu te amo, Diego. And here's a picture just a few days ago by the pool. And he likes this hair. Just to finalize, I'd like a small surprise here. So I was thinking on if somebody from outside the association would come to us and ask us to introduce the association, how would we do that? What would we tell? So let's see, and I hope you enjoy it. And this is my last slide. Thank you.
Patient care changes every day. As doctors, we are dedicated to sharing our knowledge of the treatment and care of patients who are affected with diseases of the liver, pancreas, and biliary system. Our passion is to improve education, training, research, and patient care, and to contribute to innovation in these areas. In 1994, we were a group of more than 10 enthusiastic doctors inspired by a dream. Today, we are more than 1,000 united throughout the Americas. In the past 25 years, the AHPBA has hosted annual meetings and provided educational workshops and courses in an effort to increase the awareness of what is happening in our field of surgery. With support from the Foundation, we are committed to increasing more of our time and energy to improving the care, education, and the quality of our patients' lives. In the end, we are the sum of our dreams and of the effort every member has devoted to our patients all over the continent. America's Hepatopancreatobiliary Association. Focus on scientific evidence and integrated care.